if I click down. So I guess it is a bit shocking to think that there isn't a natural, if you like, specialty that deals with thrombosis, given how common it is. And I'm just going to quickly tell you how common it is. Talk a little bit about the post-thrombotic syndrome, which is a fancy set of medical terms, to talk about what happens to people that have had blood clots, particularly in the legs, what it's like to live having had a blood clot, and then hopefully give you plenty of time to ask questions. So how common is it? I mean, you all know about strokes and heart attacks. You know, everyone knows that if you develop severe chest pain and you're sweaty, you need to call an ambulance. People know about stroke. Again, written all over ambulances, the FAST acronym is everywhere. And a lot of attention, a lot of political time, a lot of money is spent on dealing with strokes and heart attacks. And they are number 1 and 2 in terms of killers in Europe. But number 3 on the list is actually VTE. So number 3 on the list often doesn't get airtime. It's a bit like, you know, what's the 3rd biggest city of Spain? I mean, I've been to Valencia, but no one knows really about Valencia. They all know it is lovely, but it's forgotten because of Madrid and Barcelona. So there's more than 150,000 Europeans that die every year of VTE, and many more that live with the effects of VTE. And we have specialists that deal with heart attacks and specialists to deal with stroke. So where are the specialists that deal with VTE? And that's something that I've been working with Fionnuala and Anne-Marie, trying to develop a clinical program, and we are making some progress in that area, I have to say. So after you've had blood clots in your leg, you end up sometimes with permanent pain and swelling. And the reason for that is that the little valves that are working inside your veins, inside this low pressure system, get damaged. So the venous system is very different from the arterial system. So the venous system is a low pressure system, and because it's such a low pressure system, it's much more affected by gravity. So you can stick your hands up in the air for quite a long period of time, and because the arterial pressure is so good at getting blood to the tips of your fingers, you know, although it'll be painful, you'll still perfuse your fingers. But the venous blood will drain away ultimately. So gravity is, in a way, what these valves, these little valves, particularly in the leg veins, try to work against. So they allow for flow back from your feet, back towards your heart. And they're very delicate little things. And once a clot develops in those valves actually don't repair themselves. And they are the severe consequences of a DVT. So this is the venous system that Fionnuala was talking about, with the pelvic veins at the top there, leading down into the thigh veins and to the lower limb veins. The veins that are below the knee, you can see down there, the tibial veins and the perineal veins, are the most affected by gravity. And but ironically, if clots develop in those veins, i.e. below the knee, they do not embolize to the lung. There's no evidence that they do. And in fact, in some centres, they wouldn't even be treated. With one proviso: if the event or the thing that's inciting the clots doesn't go away, then what was a below knee DVT can become an above knee DVT. And once your clot is above the knee, you have roughly a 50% chance over the next 6 months, if left untreated, that clot will move to your lungs. And that is the great concern. And that is ultimately, we treat blood clots in the legs for 2 reasons. One, to try and get rid of the pain and swelling, but the main reason we treat it is to prevent blood clots going to the lung. That's what a DVT looks like. Now, I mean, lots of things can cause pain and swelling in your leg. Clots are one thing. Problems with your knee, things called Baker's cysts, which is like a blowout of the knee joint, can mimic DVTs. Infections of the lower limb can mimic a DVT. An injury to the limb can mimic a DVT. Lots of things can masquerade as a DVT. But swelling would be the most common thing. And when we're quantifying swelling, we tend to measure a certain circumference of the calf, usually a few centimeters from the knee joint, just to get a specific measurement. And anything that's greater than 3 centimeters different from one leg to another would be considered significant. Now, a lot of people have permanent swelling, And so it's very difficult, for instance, if you've got permanent swelling or swelling from another cause, to try and work out whether that is potentially a DVT or not. Basically, the DVT works, so it's a thrombosis, it's a clot, and what it does, if it's completely blocking the vein, you would imagine it's just like any river that you block. Obviously what happens is pressure builds up behind the blockage, and that is what's causing the pain. That's what's causing that heavy dragging sensation. And as you would imagine, if you would stand up and you add that gravitational effect makes that pain, makes that heaviness, makes that swelling even more. If the clot is incompletely blocking the venous system, that swelling and pain and dragging may not be as bad because you're still going to be getting some blood flow. So this is what those little delicate valves look like. They tend to be in specific places. There's a set of valves about a hand width below the knee, and there's another set of valves a hand width above the knee. And then if you put your hand sort of in your groin, there's more valves at around the groin level. And I mean, these valves are paper thin. They're tiny little things. They're very effective at stopping backflow, if you like. But you could imagine what would happen if you got a clot across that valve. The clot expands, and even once the clot is treated and taken away, those little valves are left damaged. And that's the reason you end up with the post-phlebitic syndrome. Can you surgically repair those valves? Common question asked. The answer is no, we don't have the technology to do that, I'm afraid, at the moment. That increased pressure in the venous system following the clot actually causes inflammation. So you'd imagine the vein distends and causes back pressure through the venous system to the tiny little venules. So these are micrometer thin little venules that ultimately are draining the capillaries, and they get damaged and they get scarring around them, and then the blood leaks out through those damaged vessels, and that's why you end up with that sort of it's like a hemosiderin-y, blacky, grey looking skin colour. That is, if you like, the breakdown product of blood seeping through those damaged little inflamed vessels that are there because of that high pressure. And as well as the blood leaking out, causing that sort of staining we call venous eczema, this sort of grey-browny staining, can also lead to scarring, and the feared complication of the post-phlebitic syndrome is ulcers. So much inflammation, so much scarring that the skin actually breaks down and you're left with ulceration in your skin, and those ulcers can get infected. So this is just a pictorial display of the sequence of events. So this is the early stages. So what you've got there is that sort of staining, if you like, the staining breakdown products of red cells. You can see in the middle it's red, but around it looks like a bruise almost. So that's the beginning. It tends to happen in that particular area. We call that the gaiter area, but it's just the area around the ankle that's most susceptible to the effects of gravity. That's longer standing with skin discoloration and lymphedema, chronic swelling, and that's the feared complication. Again, in that same area, in the gaiter area around the ankle, where you've now got the skin completely, the skin and the dermis, the epidermis and the dermis, the superficial lining of the skin and the underlying dermis completely broken down, and you can see soft tissue there and inflammation. So that's the dreaded complication. Unfortunately, I'm sure as many of you know, these symptoms and signs of the post-phlebitic syndrome, once present, can go on for quite a long time. They can actually start quite quickly as well. You see them most commonly in patients that have had a big DVT. So the bigger the DVT and the more proximal, what I mean by that is the closer up it is to your groin, is the greater likelihood of this occurring. The risk factors, again, the bigger the clot, the more likely. If there's a complete blockage of the vein as opposed to a partial blocking, that makes it more likely. If you've had more than one DVT, so many patients get more than one DVT, and certainly recurrent insults to those delicate little valves increases your risk. Varicose veins we've talked about earlier so the veins I'm talking about are the veins you can't see. the varicose veins, these are the superficial veins, these are the veins you can see, these are the veins that people get surgery for, most often suffered by women who've had pregnancies, multiple pregnancies. They can also contribute as well, because what's happening in these varicose veins that actually feed into the deep veins is pressure is increasing there. So they are also a risk factor. Obesity is another risk factor, and unfortunately so is getting older. A lot of people, I mean, I do a blood clot clinic every week. I've been doing it for 20 years, and really probably one of the most common questions I get asked in my clinic, and maybe I'll get asked it even again today, is how do I know my clot is gone? You know, I don't want to get this post-phlebitic syndrome. Can I get another scan? Can you reassure me that these wonderful medicines that you've given me have made my clot disappear? The reality is that well, first of all, the direct oral anticoagulants and heparin and warfarin, I mean, they're incredibly effective at inhibiting blood clot formation. If you're taking them, only under very rare circumstances will blood continue to clot. But what we do know about blood clots below the knee is nearly a third of them, despite adequate anticoagulation, don't fully recanalize. And there's nothing we can do about that. But we do know that that is a predictor of developing the post-thrombotic syndrome. That's not a failure of anticoagulation. It's got more to do with where the clots are in the deep veins, particularly below the knee. But it is a predictor of the post-thrombotic syndrome. How do you avoid the post-thrombotic syndrome? Well, the best way is not to get a DVT. And if you do get one, get it treated as quickly as possible. What we do know is the longer the clot's been there, the more likely permanent damage is going to be done. The more likely that clot will move to your lungs and potentially be fatal. But obviously getting the diagnosis early, quickly, and starting on the appropriate anticoagulant. We do occasionally use low molecular weight heparin and warfarin, rarely though. Warfarin, on the whole, is a medicine that the ISTH, the International Society of Thrombosis and Hemostasis, the ECP, that all the big international societies would not recommend the use of warfarin now, except for a few circumstances, a rare clotting disorder, and the most common reason warfarin will be used now would be people that have metal heart valves. Low molecular weight heparin we do use in the setting of a deep vein thrombosis in the early stages, particularly if it's a massive clot and there's massive leg swelling. And the reason we use heparin as opposed to a DOAC in that circumstance is that the heparins seem to have some anti-inflammatory effects as well that the DOACs don't have. So we would occasionally, for the first 2 weeks, potentially in a large DVT, use heparin. There's also the ability to remove these clots manually with a catheter, or giving a medicine that dissolves the clot through a catheter. On the whole, there are only very rare circumstances where that is done. It's not offered in every hospital. It comes with certain risks. I have referred 2 people in 20 years for this procedure. On the whole, it's not required, and sometimes its risks outweigh its benefits. Stockings, again, a question asked weekly. Do I need to wear stockings? I've had a DVT. Do I need to wear stockings all the time? Do I just need to wear them for flights? What's the story? So after having had your first DVT, we do not recommend the routine wearing of compression stockings. There is no evidence that the routine wearing of stockings after a DVT prevents recurrence or prevents the post-phlebitic syndrome. But stockings are useful in people that have persistent swelling from a symptomatic perspective, and there's no problem with wearing them for that reason, particularly for people that are having to spend a lot of time on their feet. Often find at the end of the day the leg is swollen, it's dragging, it's heavy. If it's for symptomatic relief, there's no problem with that. If you've got a venous ulcer, it's a different type of compression stocking you need, and compression stockings are the treatments for venous ulcers, and I'm going to mention them in a couple slides down the line. Also to remind you that there are mimics of DVT, and it's the bane of our life, and it's a constant concern that we miss the diagnosis because we're thinking about other things. We're not thinking about DVT. We're thinking about Baker's cysts, these cysts, knee blowouts, if you want, for another better term, blockage to the lymphatic system, or trauma, common mimics. So other than preventing the clot, what can you do about it? Well, gravity is the killer with PTS, so trying to avoid gravity. I can see your leg is up in the air there, my friend, and I'm sure that's because of this very syndrome. What I recommend to my patients is, I mean, if you can afford one of those fancy beds that, you know, elevate the limbs or whatever, that's grand. But you can do some very simple things. So if you get a pillow, a normal sized pillow, and you stick it under the mattress, not on top of the mattress, under the mattress, that'll raise the end of your bed. It'll get squished by the weight of your mattress, but it'll raise it by an inch, maybe half an inch. But that half an inch while you're sleeping is all you need. Remember, you're in bed for a third of your life. And during that third of the time, when you're in bed, which if you have PTS, you'll know is your most comfortable time because gravity isn't there with you, you can work even against gravity. If your leg is just slightly elevated, you're enhancing that venous return during that period of sleep. And that will give you at least a good couple of hours the next morning that you wouldn't have had otherwise. So it's a really simple little trick. The compression hosiery, as I said, if you get symptomatic relief, no problem. Skin softeners, so the paraffin, hydromoly ointments, very, very useful. Topical steroids if you're getting that redness and inflammation, so things like hydrocortisone ointment, the steroid creams also can be useful. As I said, surgical interventions, controversial. Stenting surgery, bypass, again, controversial. I have to say, I think that doctors are funny creatures. You know, that there are people that do these procedures that swear by them, and others would be more questioning of the evidence base for them. All I would suggest that if your doctor is considering doing a manual thrombectomy as opposed to standard anticoagulation, that you get more than one opinion, because we have seen problems. What's the risk of DVT in the post-thrombotic syndrome? Unfortunately, if you've had a big DVT above the knee, completely occlusive, it's nearly 1 in 2. So the risk is very, very high. Now, of course, there's various levels of post-thrombotic syndrome. There's very mild and very severe, but needless to say, it is very common. It affects quality of life. It affects your ability to work, particularly if your work involves being upright. We're bipedal primates. We spend a lot of the time on our feet. So it is very significant. So the best way to treat it is to avoid it. I'll mention exercise as well before I finish up and take questions. I would regularly recommend exercise as a supportive treatment for the post-phlebitic syndrome. So if you imagine your veins, your deep veins, are surrounded by muscle, and because your valves aren't working, the only backup you really have is muscle strengthening. So particularly exercises that strengthen your muscles, particularly in your lower limbs, that avoid gravity. So gravity is the killer with PTS. So swimming, cycling, pounding the pavement isn't great for the gravitational effects. It's great for strengthening, for sure, but if you can exercise and avoid the effects of gravity to strengthen those muscles that support those veins, that will avoid that swelling and the gravitational effects of pressure, all the better. So thanks for listening, and I'll take any questions.